Sandy, have you let, oh, there we go. People are coming in. You go ahead and put that in presenter view, Eric, and we'll just wait one more second for more people to join. All right, when we hit 50, I'm going to introduce you. Of course, it's stalled out now. Well, we'll go ahead and get started so that Dr. Engels has time to give his fascinating presentation. So it's my pleasure to introduce Dr. Eric Engels, who is branch chief for infections and immunoepidemiology at the Division of Cancer Epidemiology and Genetics at the NCI. So DCEG is the intramural research branch of unit for NCI, doing epidemiology of cancer in many different forms. And you know, I could recite his impressive training, including MD at Harvard, a residency at Brigham and Women's in internal medicine, and a second residency or fellowship in infectious disease at Tufts, where he also picked up his MPH. But I just wanted to give a short anecdote about serendipity in science. So a couple of years ago, I was in Houston for a meeting on pediatric cancer disparities, and at the hotel counter checking in, and I look over and there's Eric, and we knew each other back in the day, but hadn't seen each other in many years, but I recognized him and I said, "Oh, hey, Dr. Engels, are you here for the leukemia meeting?" And he said, "No, I'm just here to visit my son who goes to Rice." But we got to talking and mentioned a novel finding that cytomegalovirus could cause pediatric ALL, and you know, a collaboration was born of that. So without further ado, I will let Dr. Engels take over. And you know, I'm sorry that we intended to have you here in person, but circumstances prevailed. So we do hope to get you out here in person someday. So take it away, Eric.
Thank you, Logan. And it was really nice of you to invite me to present today. And I'm sorry I couldn't be there in person with all of you. And it was a real surprise a few years ago when we connected, and it's been nice working together since then. I'm going to be talking today about cancer in solid organ transplant recipients, and in particular focusing on work that we've done at the National Cancer Institute on a study called the Transplant Cancer Match Study. So the objectives of my talk today are to help you understand the design and analysis of epidemiologic studies that utilize linked registry databases, to understand patterns of incident cancer among solid organ transplant recipients, and understand survival outcomes following a cancer diagnosis among transplant recipients. So solid organ transplant recipients are a population of unique interest to us in understanding cancer because they are immunosuppressed. They take medicines to prevent rejection of their donor organ. And this immunosuppression persists as a result of these medications throughout the time after they've received their organ. And as a result of that immunosuppression, the risk of cancer is elevated in this population, although, as I'll describe to you, it's a rather specific spectrum of cancer, and it differs from what we see in the general population. There's been much less research on clinical outcomes after a cancer diagnosis, specifically recurrence and mortality, and I'll talk to you some about that. And in order to get at these questions, we need to do population-based research studies because cancers are rare, and so we need a large number of recipients. We need good ascertainment of cancers in these populations, and we need data on transplant and cancer-related factors. And it was thinking about these issues that led me to design the transplant cancer match study. This is the state of the field in 2006 when we were thinking about this. There had already been a number of studies of cancer in solid organ transplant recipients done in various countries throughout the world. These studies have a reasonable sample size with the number of recipients in the thousands or tens of thousands, but they're really not large in terms of studies of cancer because, as I mentioned, cancers are somewhat uncommon. They mostly focused on kidney transplants, but there are other organs that are transplanted, and these studies didn't have information on those. And many of them did not use cancer registry to ascertain cancer incidence, where that cancer registries provide really the gold standard for identifying cancers. And so that led us to design the transplant cancer match study, which is a linkage of two data sources. On the left, you see the SRTR, which is the Scientific Registry of Transplant Recipients. And this is the US National Transplant Registry. It covers all US organ transplant recipients, candidates waiting for a transplant, and donors. There's information in this registry such as recipient and donor demographics, medical conditions in the recipients that led to the transplant, the organ characteristics, the immunosuppressive medications, and the cause of death when somebody dies. We electronically linked this database to multiple state cancer registries. And this allowed us to identify cancers in this population. And the cancer registries include, again, demographic information, but then details about the cancer diagnosis, such as the date of diagnosis, the characteristics of the tumors, the treatments. And when we originally did this study, we spent a number of years engaging these various cancer registries, and we came up with 13 registries that contributed data to our initial analyses. This covered the period of time from 1987, when transplantation started in the US, through 2008. We had 175,000 transplants, or 40% of the US total, and we had over 10,000 cancers in this population. More recently, we've updated the study and we have much more data. We use something at the National Cancer Institute called the Virtual Pooled Registry, which is sort of a collaborative effort of state cancer registries to enable researchers to collect data all at once. Although it's not entirely straightforward, it does facilitate much larger engagement with registries. And we have 32 cancer registries now contributing data on more than 450,000 transplants, 68% of the US total. So how do we use these data? Well, it's useful to think of this database as a virtual cohort. The cohort of transplant recipients is identified in the transplant registry, and they're followed from the time of their transplant until they die or they're censored. And through the linked cancer registries, we can figure out which of these people develop cancer and what types of cancers that they have. And then we can also calculate the expected number of cancers that would be predicted to occur in the general population if they were followed in the same way. And the ratio of the observed to expected counts is called the standardized incidence ratio, and it's a relative risk comparing transplant recipients to the general population. So let me show you some of our data on cancer incidence and also risk factors for cancer. So this is from our initial report, where we described the spectrum of cancer in 175,000 solid organ transplant recipients. And you can see here that the population mirrors what the general transplant population looks like in the US. Most of these individuals are male. The average age of transplant is about 47 years. The most common organ transplanted is kidney, about 60%, but about 20% are liver, and then smaller proportions of heart, lung, or other organs are transplanted. And I'm showing you here the risk estimates for various cancers. First, overall cancer. You see the observed number of cancers, the number expected, and then this ratio, this relative risk, the SIR, is 2. So about a doubling of risk compared to the general population. But it's not doubled for every cancer. There is a specific spectrum of cancer, if you will. So here I'm showing you risks for virus-related cancers and other infection-related cancers. The most common cancer in solid organ transplant recipients is non-Hodgkin lymphoma. And this is a cancer that is caused by Epstein-Barr virus in this immunosuppressed population. And the SIR is about 7.5. There's also an increased risk for Hodgkin lymphoma, which is further down in the table. That's also caused by Epstein-Barr virus. And then you see increased risks for liver cancer, which is caused by hepatitis B and C, Kaposi sarcoma, which is caused by the Kaposi sarcoma-associated herpes virus. The risk here is very increased. And then a number of HPV-related cancers, human papillomavirus. The exception being cervical cancer, where the SIR is very close to 1. And we think that is due to the fact that women with transplants are screened and treated for precancerous lesions. So this is a pattern where immunosuppression is probably causing these cancers because these individuals can't control or eliminate these viruses. These viruses then transform cells. Progressive genetic damage then leads to frank malignancy. The pattern for non-infection related cancers is a little bit different. There are some increased risks, but it's not across the board. So the SIR for lung cancer is around 2. For kidney cancer, it's 4.7. And for colorectal cancer, it's 1.2, a small increase. And for prostate and breast cancers, you can see that the SIRs are actually below 1, not a significant increase at all. Transplant recipients also have an increased risk of various skin cancers. That's seen here in this table for melanoma, where the SIR is 2.4. For non-epithelial skin cancers, where there's a very increased risk with an SIR of 14. And then for lip cancer, which is sort of like a skin cancer, it is UV associated, a very strong increase in risk. We also did a follow-up study focused on children, and I thought of Logan when I put the slide in because I know of his interest in pediatric cancer. Cancer is much less common among children in general, and it's true for transplant recipients as well. These are the SIRs for various cancers among pediatric transplant recipients. The great majority of these cancers are non-Hodgkin lymphoma, and the SIR is very high. It's more than 100, indicating that the immunosuppression here and primary Epstein-Barr virus infection is leading to a very increased risk for this cancer. And there's also an elevated risk for Hodgkin lymphoma, again, although it's not as common. And then there are small numbers of these other cancers, and some of them have increased risks. And we also see that some of these cancers are the type of cancer you see in children, not the types you would see in adults. So 9 of the leukemias are acute lymphocytic leukemias. 3 of the kidney cancers are Wilms tumors, and 2 liver cancers are hepatoblastomas. So, it's difficult to know what to make of these small numbers, but there are contributions here for these occurring for these specific pediatric cancers. We also looked at the contribution of transplantation to the burden of cancer in the US, and we focused in on children here, and specifically non-Hodgkin lymphoma. So on the left, you see the prevalence of transplant recipients in the US general population as a function of age. And these are children, so very few children in the general population have had a transplant. For example, in the 0 to 4 year age range, fewer than 0.01% or 1 in 10,000 children have had a transplant. And that increases a bit in the older age ranges. So it reaches for the 15 to 19-year-old group, almost 0.02%, but still very uncommon. But when you look at the cancer cases in the general population, the non-Hodgkin lymphomas, there's a much higher fraction of individuals who had a previous transplant. So again, in the youngest group, 0 to 4, almost 5% of non-Hodgkin lymphoma patients had a previous transplant. 20% of diffuse large B-cell lymphomas had a previous transplant. And then these proportions are still high, but decrease with age. And this really reflects the very low incidence of lymphomas in young people, but the very increased risk of these lymphomas associated with transplantation. We've also done some studies looking at risk factors for cancers. And a couple examples I want to share with you. One of these has to do with bladder cancer. And in particular, BK virus, which is a polyomavirus. It's a very common infection, but it can reactivate in the urinary tract. It's shed from the kidney. And in immunosuppression, it reactivates even more. And so kidney recipients are at risk of reactivation of this virus, which can lead to a kidney disease, damage to the kidney called BKV nephropathy. And there have been reports that BK virus was detected in bladder cancers in transplant recipients. And the hypothesis would be that this virus is reactivating in immunosuppressed people, that it's infecting and transforming bladder epithelial cells. And so we looked at this in our database using information from the transplant registry. We studied 55,000 kidney recipients, and the transplant registry indicated that almost 4% of these individuals had been treated for BKV nephropathy. And then we looked at the subsequent incidence of various urinary tract cancers. And in the table here, you see that BKV nephropathy was associated with an elevated risk of developing bladder cancer, an adjusted incidence rate ratio of almost 3. Now, this is based on very small numbers, but it suggested to us that this model was possibly correct, that reactivation of BK virus was somehow predisposing people to bladder cancer. And we followed this up in a study using our transplant linkage resource to actually look in bladder tumors for various viruses. So we took the cancer registry data and identified which cases were arising in someone who had previously had a solid organ transplant. And then we asked the cancer registries to help us retrieve formalin-fixed paraffin-embedded tumor blocks from those cases. And then we used next-generation sequencing to look for viruses. And we identified and retrieved 43 cases of bladder cancer from transplant recipients, which was the largest study of this topic. And we actually did find viruses in these tumors. So in the figure here, you see that there are cases where there is evidence for BK virus in both whole genome sequencing and RNA sequencing. We also found 7 cases that were JC virus positive. JC virus is a related polyomavirus to BK. So this study really supports the idea that in an immunosuppressed population, a fraction of bladder cancers might be caused by these viruses or other viruses. And the final example I want to share with you regarding incident cancers in the transplant population relates to lung cancer. So I already shared with you that transplant recipients have about a 2-fold risk for lung cancer compared to the general population. The risk varies according to the transplanted organ. So on the right side of the table, you see results from our 2011 paper, and the incidence or the relative risk for lung cancer is highest among lung transplant recipients with an SIR of 6.1. And in the middle of the table, you see results from a similar study conducted in the United Kingdom and similar results where lung recipients have the highest increase for lung cancer. So what's going on there? Well, lung transplant is interesting because some recipients receive 2 lungs, but some recipients only receive 1. And the idea here is that if you give a patient only 1 lung, that is hopefully enough to help them go on with their life in reasonable health, but you can then double the number of people that you treat. And so a number of transplants in the US, lung transplants are single lung transplants. And here's an example of a case report where a lung transplant recipient got a right lung, but developed cancer in the left lung. And this really points to the likely importance of this damage in the native lung, that these are individuals who have very severe lung disease. And if you only replace one of the lungs, the remaining lung is at greatly increased risk of developing lung cancer. And so this is something that we studied. So first, we looked at lung recipients and analyzed their incidence of lung cancer according to which lung they received. So we calculated SIRs for both left lung and right lung cancer. And they're both about the same here, about 5. So 5-fold increased risk compared to the general population. But it really varies depending on the type of lung transplant that the recipient had. So if they got a left lung transplant, the SIR is not increased in the left lung, it's very increased in the right lung. And if they got a right lung transplant, it's very increased in the left lung, but not the right lung. And if they got both lungs, they don't have an increased risk in either lung. So again, it points to the native lung as the issue. And when you combine the lungs, we can see that 84% of the lung cancers are occurring in the native lung, and that the increased risk, the SIR, is elevated only for the native lung with an SIR of 13. And the donor lung doesn't have an increased risk at all. And that points to the importance of native lung disease. But we did some more thinking, and we did some additional analyses. And one of the things we realized is that that's probably understating the risk of lung cancer in the donor lung. So first of all, lung donors are screened for lung disease and for lung cancer. And so any lung cancers that develop in donor lungs are arising in that setting where presumably there shouldn't be any lung cancers at all. And the other thing is that donors are much younger than their recipients. So when somebody dies and they become a lung donor, the median age is 28 years. But the recipient's median age is 54 years. And when we did our initial calculations of those expected counts for the SIRs, we based them on the recipient characteristics, including the recipient age and not the donor characteristics. And so when you actually use donor characteristics, and the expected counts then become much lower, and the SIR is actually 5 for donor lung cancer. And I think that's a more accurate assessment of what the risk is of lung cancer in that lung. It is increased, and I think it reflects the effects of immunosuppression, the infections, chronic lung infections that recipients might develop, and rejection, chronic rejection of the donor lung, which could damage the lung and promote the development of cancer. So this is an example of the kind of study we've done to try to understand what causes cancer in the transplant population. So I'm going to change gears and talk about cancer outcomes, specifically survival. So I've talked so far about this scenario where someone gets a transplant, they're followed over time, and some of them develop cancer, and we calculate the incidence of cancer, and that's our outcome, that's our endpoint. But we can also look at this scenario where we take the cancer patient and we look at their survival after their transplant. And that's a different question, and it's interesting. We really got interested in this question because of the advent of immunotherapy, effective immunotherapy for cancer, which really has been a remarkable advance. And as most of you probably know, the idea here is that some cancers express immune checkpoint proteins, which allow them to evade the immune system and to grow and metastasize. But there are drugs, checkpoint inhibitor drugs, which block these checkpoints and activate the T cells and allow the T cells to destroy the tumor. And these are highly effective for a number of cancers, as shown in this table. And so the implication here is that if you can boost immunity and help a cancer patient achieve or maintain remission, then probably the converse is true, that if you give a cancer patient immunosuppression, or if they have immunosuppression already when they develop cancer, that those medications that weaken the immune system probably could hasten the recurrence of the cancer or lead to death due to cancer. And so that's something that we wanted to study. And another impetus for this research was from this study of melanoma in solid organ transplants that we did. Here I'm showing you on the left the standardized incidence ratios for melanoma as a function of time since transplant, and for the different lines, the stage of diagnosis. So the red line is for localized stage melanoma, and the SIR is about 1.5, regardless of how long you follow someone after their transplant. But for regional and distant stage melanomas, the blue and yellow lines, they're actually much higher SIRs in the period, the first few years after transplant. And we also saw that for regional and distant stage melanoma, there was an association between the receipt of polyclonal antibody induction, which is an intense form of immunosuppression, and an increased risk of these stages of melanoma. And so we put this together in the following model. We hypothesized that the blue and the yellow curves are representing diagnoses of transplant recipients who actually had melanoma at the time of their transplant. They had a small localized melanoma, but it was undiagnosed. And then when they were given intense immunosuppression, induction immunosuppression at the time of transplant, the melanomas grew, they metastasized, and they were diagnosed at advanced stage. So this again points to the importance of immunity in not just the risk of cancer, but the stage or the outcome of cancer. And so in this study, we actually tried to address this question directly. We wanted to ask, does a transplant recipient with cancer have worse survival than other cancer patients in the general population? And they're going to have worse survival because of their transplant, because they have many medical complications that other patients might not have. But we actually focused in on cancer-specific survival, which is related to death from the cancer itself, because that would reflect the biological processes and immunosuppression. So we started with the cancer registries in our study, general population cancer cases. We found 7 million cancer cases across 16 different sites. And then using the linked transplant data, we identified 11,400 who had previously had a transplant. And then we followed these cancer patients from their cancer diagnosis till they died or they were censored. And these are the results, the main results, where we're showing cancer-specific mortality hazard ratios associated with having a previous transplant. And that's the middle column with the confidence intervals off to the right. And the bottom line here is that having a prior transplant, being immunosuppressed, is associated with an increased risk of dying from your cancer. For certain cancers, notably melanoma, where the hazard ratio is 3, for bladder cancer, where it's 1.9, for colorectal cancer, 1.8, and for other cancers as well. Many of these cancers are the same ones where immunotherapy has been proven to be effective in treatment. So this does support this model that I've been suggesting to you. And then we did an additional analysis focused in on local stage cancers, where the patient had received potentially curative treatment. We thought these were the best cases where prognosis should be very good, and transplant recipients had an even worse outcome than people in the general population. So for melanoma, now the hazard ratio is 3.8, and for colorectal cancer, it's 2.8. The final topic I want to talk about is a slightly different scenario, again relating to survival. But here, we're talking about patients who have cancer before transplant. So these are individuals who have a cancer diagnosis, they're treated, hopefully they're in remission, but they develop end-stage organ disease and need an organ transplant. And the question is, what's their outcome after transplant? And this is a clinically important question because transplantation is a scarce resource. And if immunosuppression is going to accelerate those cancers, make them more aggressive, and the patient's going to die, then giving an organ to that person is potentially bad for them, and it also deprives other people of the chance of transplantation. And this is an increasingly common issue. Here are data from the US Transplant Network on the prevalence of the cancer diagnosis among kidney transplant recipients. The prevalence is generally increasing over time. That's shown most clearly by the solid black line for solid organ cancers, where it's been rising very steadily through 2015 or so, the last years that they have data. And there are guidelines here for what to do in this situation, clinical guidelines, but they're not based on really good data. And so typically having an active cancer is considered a contraindication to transplant, except in the setting where transplantation is the treatment for cancer. And that is most notably the case for hepatocellular carcinoma, where liver transplant can be curative. But it's also true probably for indolent low-grade cancers such as ductal carcinoma in situ of the breast or low-grade prostate cancer. But other patients without those exceptions need to have received curative treatment and be in remission from their cancer. And typically they are asked to wait 2 to 5 years after their cancer treatment, although the interval is really uncertain. And as I mentioned, the quality of evidence is quite low. And we had the idea to approach this in a novel statistical way. And I got this idea from looking at this paper on the right, where the researchers took data for melanoma from the general population. So these are cancer registry data where the melanoma cases are stratified by stage of diagnosis, and they're looking at survival. And then these horizontal and vertical lines are the author's attempt to identify where these curves plateau. And the idea here is that you can benchmark what you recommend for people being considered for transplant by using general population cancer data. If the prognosis is good enough, in particular, if the survival curve has plateaued, you might consider that the person's been cured of their cancer, that similar patients don't have a continuing mortality from their cancer. But the challenge here is that it's very hard to figure out where these curves plateau. And it's somewhat arbitrary, I think, as you can appreciate from the example that is presented in the figure. And it also assumes that immunosuppression won't make the risk of recurrence and death from cancer higher, that you can actually use the general population as a benchmark, and that hasn't been assessed in any way. But this was the idea for motivating our study, which is based on this idea of statistical cure. So here's a hypothetical survival curve for a group of cancer patients followed over time after their cancer diagnosis. And the idea is that you can break up this population of cancer patients into 2 groups. A population below the line who are cured of their cancer. They've actually been cured of their cancer since the day they were diagnosed, and they're not going to die from their cancer, no matter how long you follow them. And then there's a group of people above the curve, above the line, who are uncured, and all of them will eventually die from their cancer. And the challenge is you don't really know who's in which group, but you can model the probability that a person is in one group or the other. And you can base these models on various characteristics of the cancer patients. So in the left orange rectangle here, I'm showing that you can break down this population of people who are alive 1 year after cancer diagnosis into the group that's below the line who've been cured and the group above the line who have not been cured. And about, I would say, 60% of those patients who are still alive are cured of their cancer. If you follow them longer, the cure probability increases, the fraction of people below the line increases, and the idea would be that you could offer transplant when this probability is high enough, because it makes sense to give a transplant to a person who's likely cured of their cancer because that cancer won't recur. And so we built these cure models for 17 different cancers using data from the US general population in our cancer registries. We did it separately for each cancer site, and we used data for our models on age, sex, cancer stage, and treatment of the cancer. And then we applied these models to estimate the cure probabilities for cancer patients at the time of their cancer diagnosis, and for the transplanted patients, the time of their transplant. And these are the characteristics of the cancer patients for whom we built the model. So 10.5 million cancer patients in the general population. And the diagnoses here are the typical, most common cancers that you see in the general population. So a large fraction of prostate, breast, colon, and lung cancers. And then here are the characteristics of the patients who eventually got an organ transplant, 5,425 of them. And the distribution is a bit different here, and this reflects the survival of these cancer patients long enough to be considered for transplant, and then the selection of patients for transplant by the providers. And so you see a very large fraction of prostate cancers and breast cancers, very few lung cancers because the mortality is so high, and there's a selection against such patients to be offered transplant. And a higher fraction of good prognosis cancers, for example, thyroid cancer. And this figure shows some of our key results from the study. These are the cure probabilities for the cancer patients. So I'll focus first on the red histogram. And this is the cure probability distribution for the 10.5 million patients in the general population. And this is at the time of their cancer diagnosis. And it's a bimodal distribution with a median of around 0.62, 62% chance of being cured of their cancer. Some patients are up to the right. There's a sizable number of patients, in the cure probability range of say 60 to 80%. And then there's a proportion of people down on the left side with very poor prognosis, with a cure probability of 5 to 15%. And those patients are predicted to eventually die from their cancer. In comparison is the blue histogram, which is laid over the red one. And these are the cure probabilities for the transplanted patients at the time they were transplanted. And these are much higher. So the median cure probability is 94%. And this reflects the selection of these patients. They're thought by their providers to be appropriate candidates for transplant. And on average, there's more than 5 years, 5.7 years between cancer diagnosis and transplantation. So there's been an interval of time where they are sort of declaring themselves to be free of cancer. So pretty good prognosis, but I also want to call your attention to the fact that there's a left tail on this distribution, and that there are a number of transplanted patients with cure probabilities that are a bit lower, down around 75% or certainly well below that. And so what we did was look at whether these cure probabilities were predictive of the patient's outcome after their transplant. Could you use information available at the time of transplant on the prognosis to predict their survival? And the answer is you could. So here I'm showing you 3 curves for the cumulative cancer-specific mortality for these transplanted cancer patients. And they're stratified according to their cure probability at the time of transplant. They're divided into thirds or tertiles. So the low tertile has an elevated mortality from cancer after transplantation. And in a Cox model, where we included a number of variables, we showed that this cure probability is predictive of death from cancer, that the low cure tertile has twice the risk of dying from cancer, hazard ratio of 2.08, compared to people in the highest cure tertile. And this was highly significant. We also included the transplanted organ in these models. This is of interest because the organ is one of the measures we use to assess the intensity of immunosuppression. So heart and lung recipients get the most immunosuppressive, the most intense immunosuppressive medication regimen. And liver transplant recipients get the least, and kidney are in the middle. And there's really no association here, which suggests that the intensity of immunosuppression is not a factor in leading to recurrence of cancer or death. We also looked at some other factors, including induction immunosuppression and various baseline medication combinations. And these were not predictive of cancer-specific mortality. We also looked at the use of mTOR inhibitors, mammalian target of rapamycin inhibitors, which are thought to have anti-cancer properties, and these were not protective or predictive of mortality. So it's really only the cure probability. And we also looked at whether the cure probability was predictive of non-cancer mortality. And as we expected, it was not. That this is a factor related to cancer, and so it doesn't predict mortality from other causes in this population. But it is associated with overall mortality because of its effect on cancer mortality. So the low tertile has a hazard ratio of 1.2, or a 20% increased risk of dying overall compared to people in the high tertile. So we think this is an attractive way of thinking about sort of prognosticating for cancer patients being considered for transplant. It could be used to help put people on a uniform scale across different cancer diagnoses. And if it's validated, it could become clinically applicable. We could, for example, develop a tool for this that providers could use. The other thing we've done more recently is look a bit more at pre-transplant cancer and mortality in another way. So we did an analysis where we showed that having a pre-transplant cancer is associated with an increased risk of developing a post-transplant cancer. The hazard ratio here is 1.8. So that's not terribly surprising, because in general, having had a cancer diagnosis puts a person at risk for developing other cancers at increased risk. And there are various explanations for that, and they're not specific to transplantation. But we also looked at the causes of death in people who had a pre-transplant cancer. And these are cancer causes of death in people with a pre-transplant cancer. And my expectation was that the pre-transplant cancer would be the cause of death in these individuals, but that's not true. Only 34% of the cancer deaths are indicated as being related to the pre-transplant cancer, and 52% are actually due to post-transplant cancers. And this is important because it makes sense, because the patients with a pre-transplant cancer are being selected because their providers think the cancer won't recur. So in many cases it doesn't, but if it puts them at increased risk of a post-transplant cancer, we know that those cancers have a bad outcome, have a higher mortality. And so it's probably what's explaining this contribution from post-transplant cancers. And it has a different message. Part of the message is that we need to do a better job of screening people offered transplant, but we also need to follow these people after their transplant and screen them for developing a new cancer, because this is actually contributing to their mortality. Okay, so I'm just going to wrap up with a few observations, a few conclusions. So as I think I showed you, transplant recipients have an elevated incidence of certain cancers. These are related in large part to immunosuppression, in many cases to viruses, and there's also contribution from end-stage organ disease. There's a more complicated picture with regards to survival outcomes after a cancer diagnosis. We've shown that mortality is elevated for cancers that develop after transplant in the setting of immunosuppression, and this probably relates to the fact that people who develop cancer after transplant can't control their cancer as well, using the various aspects of the immune system that help us contain cancer. We didn't see any evidence that immunosuppression increases mortality if the transplant occurs after the cancer. Now there might still be an effect, but we haven't been able to show that. So that's occurring after the person's been diagnosed, treated, and there's some wait period. And it looks like that the immunosuppression doesn't make those outcomes worse. But there are differences in prognosis, and I think that cure probabilities can be used to stratify transplant candidates and recipients in order to better decide who would be a better transplant recipient and who should potentially be deferred. And that transplant recipients with a prior cancer are at elevated risk of developing new cancer, and that we need to understand how those contribute to cancer, to transplant outcomes and overall mortality. So with that, I'd like to close and acknowledge my collaborators on these studies. On the left are individuals who led some of the projects that I've described to you. And I'd also like to acknowledge my long-term statistical collaborator, Ruth Pfeiffer at NCI, as well as Kelly Yu, our study manager, and collaborators at the Health Resources and Services Administration, which oversees transplant, and then the transplant and cancer registries. So with that, I'd like to close and thank you for your attention, and I'm happy to take questions.
Thank you, Dr. Engels. We have a Q&A box and a chat box. You can also raise your hand, and I think we'll be able to unmute you. And for once, I'm not going to take the host privilege for the first question, so we'll just wait. I know you have something great to ask Dr. Engels.
Maybe I'll start with a question.
Oh, yeah, there you go. It's a plant.
So I've been, become very interested lately in these cure models. They haven't received wide use as prognostic models for cancer patients, but I think they can tell us interesting things about potentially about the biology, and maybe they can be used for in other settings to help decide on appropriate treatment for patients or allocation of resources. And I wonder if anybody here has any thoughts about other settings where these models might be used, whether you think these are helpful and what they might be used for.
I'll tell you the truth. Before this morning, I hadn't thought about it at all, but I'm very interested to read your paper and wrap my head around the methodology. We do have a question that's not from the speaker. Heather Nelson asks, for detecting BK virus in tumors, how much virus is present? How confident are you that the virus negative tumors are truly negative?
Thank you for that question. So in the general population, it's very uncommon to find viruses in bladder cancers. There are, I would say, less than 1% of cases where you can find either BK virus or human papillomavirus. It's really been in transplant recipients where these viruses have been detected. And we found BK and JC pretty commonly. These viruses are shed in the urine, so it's possible that they're contaminants, but we found both, we found both DNA and RNA in a number of tumors. And we found the virus to be integrated in some of the tumors, which would indicate that the virus is present in, at least one copy per tumor cell. And frequently it was multiply integrated, so it would be present much more commonly than that. We didn't actually quantitate the amount of BK virus DNA, but based on that, we think that, the virus is present in these tumors. And also we were able to show expression of the large T antigen, which is a key oncoprotein of polyomaviruses in some of the cases, not all. So it was a bit of a mixed bag. For some of the cases, the evidence was a little spotty that these viruses were there and, in every tumor cell and leading to the cancer. But for some of these, the evidence was quite a bit stronger.
Eric, we have a couple other questions trickling in. So
good.
David Largaspada asks, how can cell-based immunotherapies be employed in transplant recipients with cancer safely?
Oh, that's a great question. So before I turn to cell-based, I should also mention checkpoint inhibitors. So there's a lot of interest in using checkpoint inhibitors in treating advanced stage cancers in transplant recipients, solid organ transplant recipients. I find this surprising. I'm not a clinician, and I know that people who treat these patients are reaching for effective therapies in many cases, but these patients are immunosuppressed for a reason. And if you give checkpoint inhibitors, you can prompt rejection of the organ. And that's very well described. There's a very high risk of that. But still, people want to do that. I should also mention that part of the treatment for cancer in this setting is to reduce the level of immunosuppression. So to remove one drug or taper the doses of the drugs. There is the risk of rejection. So people are trying to thread the needle here on getting better control of the cancer at the same time that they need to preserve the organ. Now, cell-based therapy is a bit different, and I'm not aware of many studies on this. The setting where it's been most explored is in the treatment of lymphomas, PTLD, post-transplant lymphoproliferative disorder. There are labs that have developed cell-based therapies that can be infused into these patients, and there is a response rate. I don't think my sense is it's not fully developed yet, and it's not that effective, but it's promising. And it doesn't pose a great threat of rejection because these are targeted cells, right? So that the immune cells that are infused are targeted against the cancer and shouldn't, there's a cancer antigen that they're targeting. And so it shouldn't cause rejection. I don't think it's associated with rejection. The checkpoint inhibitors are definitely associated with a high risk of rejection, but I'm not aware of the cell-based therapies having that high risk.
It's great that you have considered answers at the ready for some complex questions. Here's the last question from Brent Cleveland. Did you find any evidence of solid organ transplant patients having more advanced cancer at the time of diagnosis compared to non-transplant population?
Yes, we did. We did a study on that. And it wasn't true for all the cancers. It was certainly true of melanoma. I remember that. And I can't remember all the other cancers that we looked at or which cancers it was. We also included an HIV population. So we have a companion study called the HIV/AIDS Cancer Match Study, which is a linkage of HIV and cancer registries. So we wanted to find cancers that were advanced stage in both populations as a measure of an effective immunosuppression on making these cancers more aggressive, being diagnosed at more advanced stage. It wasn't that definitive of an analysis. There were also challenges in terms of we don't have good measures of engagement and care. So HIV infected people might have a more advanced stage because there's a delay in diagnosis because they don't have insurance or they're not following up in care as much as other people might. Transplant recipients are under specially active care. They tend to be very adherent with medical engagement. And so there you might see lower stage as a result of that. So we were trying to make that comparison. And I don't think that study was very definitive. It's certainly an interesting question, but I don't have a good answer for you there.
Thank you. And we have one comment, not a question, from Sally Bushhouse, who's the longtime head of the Minnesota Cancer Registration System. She says she's thrilled to see such good use made of registries. So thank you, Eric, for keeping our nation's cancer registration system afloat and relevant. It does lead me to one last question, though. When in your original linkage, it was just 13 states, and then you did the VPR. Did you end up finding more cancers in, you know, in the 13 states? Did you end up finding more cancers among, you know, people who were transplanted there that happened out of state? I know that the Childhood Cancer Survivor Study, when they finally linked to the virtual pooled registry, they found roughly double the cancers that they had expected.
You know, I ought to look at that. So we've taken a simple approach, which, you know, maybe I need to go back and revisit, but we only consider, when each person is transplanted, we identify which state they were transplanted in. And we only consider cancer diagnoses that are linked to those people from the cancer registry in that state. So when people move to a different state, we lose track of them. They might show up in a linkage to another state, and they probably could. But in order to keep the analysis simple, we've ignored that issue. But if we're missing, so we know we're underestimating cancer incidence a bit. I don't think we're missing half the cancers. I would be surprised if it was that many, but.
I should be clear, CCSS was getting self-reported cancers. And then when they finally did the linkage, they found twice as much.
They found a lot more.
Yep.
Yeah, I think the rate of outmigration is not so high that that's a big bias, but we certainly have the data. We just haven't been looking at it.
Great. Well, thank you so much for agreeing to speak. I'm sorry that it couldn't be in person, but one thing that wasn't mentioned is that the SRTR is based just down the road from the U at HCMC. So you certainly will have a occasion and reason to come here sometime when travel is more possible.
I'd like that. Thank you.
Yep. So thank you very much. And there's no applause on this virtual meeting, but I'm sure everyone is privately clapping in their offices. So
thank you.
Thank you very much.
Okay.
Take care, everybody.
Bye-bye.